In this video, we're going to look at ST elevation, or why we see ST elevation on a 12-lead ECG in someone who's having a transmural myocardial infarction. In order to get to that explanation, we're going to start by taking a look at the normal function of the heart and why we see the typical ECG changes that we see in someone who has a normally functioning heart and myocardium. So we'll start by taking a look at the isoelectric baseline. The isoelectric baseline is the portion of the heart, or the ECG pattern. We'll first start by taking a look at the isoelectric baseline. The isoelectric baseline of our ECG is representative of a net flow of 0 millivolts. So what that means is that when we're looking at the flow of electricity through the myocardium or the heart tissues, we're seeing a net flow of 0. So either the heart is at rest or the forces or electricity that is being moved through the heart, we see a net flow of 0. So there's enough opposing force that we don't actually see flow in one direction versus the other. If we take a look at this portion of the ECG, so this yellow portion that we have here, we can tell that there's a net flow of 0 because we know that this is indicative of a heart at rest. So we're looking at a heart that is not having any conduction at this point. We're not seeing any depolarization or repolarization. The heart is at rest, or we're at that in-between phase before we have another beat or the conduction system fires up again. So it makes sense that that would be that piece of the heart, or that timing would be at the isoelectric baseline, because nothing is happening in the heart during that time. The next piece that we can talk about is our P wave. So we know that our P wave is representative of atrial depolarization. So at this point, the pacemaker is fired and we're watching the atria depolarize. At this point, we do have flow of ions. We're seeing the heart contracting and ion flow through the SA node and AV node to get us to the point where we're having atrial contraction. So as a result, we see this positive deflection on our ECG. So again, this green portion is going to be our P wave. And it's pretty clear why we have a deflection here is because we're seeing ion flow and contraction of the muscle. So there is going to be a flow of electricity that can be recognized on the ECG. The next portion that we can look at is the isoelectric baseline that occurs after the P wave. So we can see that we have our PR interval, or the time between the P wave and the QRS complex. And what this is representative of is, again, we've had atrial depolarization. So the atria is depolarized, and now we're waiting for atrial repolarization. So again, there's no net flow of ions. We have seen movement of ions in order to cause depolarization, but that movement of ions has ceased, or we have a pause here, and we're not seeing any net movement of electricity because we're in the time in between atrial depolarization and atrial repolarization. So again, this orange phase, or the PR interval, it's indicative of that time in between atrial depolarization and atrial repolarization. So we're looking at that time in between where we've had depolarization has happened. Ions have flowed into the cells to cause our depolarization. Now nothing's happening until the atria is going to repolarize, which we're going to see within our QRS complex. So again, the net flow of ions here is 0. So our PR interval is indicative of the time in between atrial depolarization and atrial repolarization. The next piece that we can look at is our QRS complex. So we know that our QRS complex is going to be indicative of a couple of things happening. One is we're going to start to see repolarization of the atria, and we're also seeing depolarization of our ventricles. So we know that big QRS complex is representative of our ventricles firing, or the myocardial contraction of the ventricles. So the QRS complex is indicating that we have a patient, or we have a heart who is firing, or where the ventricles are firing. So the QRS complex is showing us obviously a flow of ions because we're having electricity flowing down the ventricles, activating that myocardial tissue, which is allowing for contraction. So the QRS complex is showing us that we have depolarization of the ventricle and repolarization of the atria. So we are seeing flow of electricity because we're having the depolarization of the ventricle and the repolarization of the atria. So now as we get to our next isoelectric baseline, again, it's not that the heart is at rest during this period, it's that we're in another of those in-between periods. So this blue line is representative of the point, or the ST segment, or the point where our ventricle has fired, or we've seen the electrical impulses travel down the bundle branches Purkinje fibers, activate the ventricle, we get ventricular contraction. And now we're waiting for repolarization. So it's not that we haven't had any ion movement, it's just that we're at a point where those ions have moved and they're no longer moving at this moment. So they may not be where they were when they started, but we're in that period before they start to try and get back to where they were supposed to be, or we have repolarization. So our ST segment, again, is one of those kind of in-between moments. So we have that in-between moment where we're kind of in between ventricular depolarization and then repolarization. And finally, we have our T wave. So when we look at our T wave, we know that the T wave is indicative of ventricular repolarization. So the final kind of piece of this is your T wave. And in that T wave segment, what we're seeing is the ventricle is repolarizing. So what we'll do is we'll take a look at the things that we've talked about here in a more sequential way in order to see exactly what's happening. And this will set the stage for why we see ST segment elevation when there is a transmural infarction. So if we go back to what we talked about, the first thing that we're seeing is the heart at rest. So this yellow stage here is indicative of a heart at rest, or when we have rest, what we're seeing is a net isoelectric baseline of 0, or we're looking at an isoelectric baseline of 0 millivolts, because at this time, no electricity is flowing. The heart is sitting idly and waiting for our next impulse. We know the next thing that's going to happen is as we have our conduction system fire, we're going to have our atrial depolarization. So next we're going to get atrial depolarization. And again, we see a positive deflection on our ECG as a result of this, because we're watching the net flow of ions towards our camera, towards our lead 2, as the atria depolarizes and contracts. The next thing that we're going to see is another isoelectric baseline. And in this period, we know that the atria has fired, but we are waiting for the atria to repolarize and the ventricle to depolarize. So although we have had flow of ions, that flow of ions has now ceased, and we're back to a net flow of 0. So again, when we take a look at this period, because we are not seeing any depolarization or repolarization, the net flow of ions is 0 millivolts. When we go to the next phase, or we go to the QRS complex, we know a couple of things are happening here. So we're having depolarization of the ventricles. So as we get to the QRS complex, we're seeing depolarization of a ventricle, and the ventricle is firing, which is helping cause the QRS complex here. And we're also having repolarization of the atria. So we can see that the atria is no longer depolarized, it's repolarized. So we're seeing that here. So QRS complex indicative of ventricular depolarization and atrial repolarization. So again, we are seeing the flow of ions because we're having depolarization and repolarization, which is going to change the flow, or how we see movement of ions across the ECG. The next period that we're going to get to is our ST segment. So again, the ions have moved at this point. So when we look at this section of the ECG in particular, the ventricle is depolarized. So when we look at the ventricle, it's depolarized, and we're awaiting repolarization. So I'm going to put those dots in here to indicate that depolarization has completed. So we've completed depolarization, and now we're at the time in between where we're waiting for ventricular repolarization. So if that's the case, if we're not depolarizing the ventricle and we're in that period in between where we're waiting for repolarization, we see a net movement of 0 millivolts. And that's why we go back to that isoelectric line. The next portion that we're going to see is the T wave. So we get the T wave here, which is going to be, again, indicative of our ventricular repolarization. So in this case, what's happening is we see movement of ions as the ventricle repolarizes. So we're watching essentially the ions go back into the places where they're supposed to be. So we get the T wave, which is showing us that the ventricle itself is repolarizing. And then finally, we get back to rest. So we're right back to that beginning portion that we talked about initially, where nothing is happening. We're at that rest period in between contraction, and we're again going to have a net charge of 0 millivolts, or we're going to see net movement of 0 millivolts. So a few things are a little bit different. So here, And here we have a ventricle that's at rest, and that's why we see a net flow of 0 millivolts. When we look here and here, it's not that the ventricle or the atria is at rest, it's that we've had depolarization happen in one of the chambers of the heart, and we are now waiting for repolarization. So ions and electricity has moved, but now the net flow is zero. You can kind of think of this as a pendulum, as we swung up to the edge of one, or we swung up one way, and we've hit that apex of the pendulum, and we're right in that in between before the pendulum switches directions and comes back down. So here you can picture a pendulum just sitting completely at rest. So we get that pendulum kind of sitting here. And here you're watching the pendulum swing. So we're actually watching that movement of the pendulum. So it's actually swinging in one direction. And then when we get to this rest period, we're waiting for depolarization, we've hit that kind of apex and we're waiting for it to come back down. So again, this period is indicative of complete rest. This period is showing us that we have movement, and here is the change in direction. So we've swung the pendulum up, it's no longer moving, it's right at that apex and it's switching direction and coming back down. So we'll use this, or having an understanding of the normal function of the heart, to then talk about why we see ST elevation on the 12-lead ECG for someone who's having transmural myocardial infarction. So now that we've looked at the normal flow of electricity in a normally functioning heart, what we want to do is look at a heart that is having a myocardial infarction. And when we're talking about ST elevation MI, what we're talking about is a transmural infarction. Or what I've drawn in here is a patient who's having a full thickness infarct to the myocardial wall. So a transmural infarct is where we typically see ST elevation on the 12-lead ECG. So this is a transmural infarction. Or as you can see, what I mean by transmural is that we have full thickness, or essentially the full thickness of the myocardium is impacted. So we're having transmural damage to the myocardial wall. And the important thing to remember when we have transmural damage to the myocardial wall is that this damaged tissue has what they call an injury potential, or essentially it's going to release ions and electricity that will alter the baseline. So we'll actually see a change in the flow of ions as a result of this. So this damaged tissue has what they call an injury potential, and because it's a full thickness ischemia or full thickness damage to the ventricle, what's often going to do is it's going to flow away from the damaged area. The other important thing to remember is that when we're looking at something like a lead 2 or a 12-lead ECG, we're looking at particular portions of the heart. So if this is the part that's damaged and this is our lead, what happens is the injury potential in a transmural infarct is going to flow away from the lead that looks at that portion of the heart, because that potential is flowing away from the damaged tissue. So in a transmural infarct, we see the release of ions, so things like potassium and hydrogen ions, which will generate current or injury potential, and that injury potential is going to flow away from the lead that's looking at that particular aspect of the heart. Another way to think of it is when we look at net electrical charge, like we talked about in the last piece, the vector or the net electrical vector will be away from the lead. So when you look at, you add up the potential from all of these ions flowing away from the damaged tissue, that creates a vector that flows away from the lead. What's important to realize is that vector is going to be present all the time now. So as that patient is having a myocardial infarction, that vector is present at rest. So where the big change comes in is where we talked about the isoelectric line, and this being the time in which the heart is at rest, or we're in between depolarization and repolarization. That's not the case anymore. So remember, we talked about that isoelectric line is typically going to have a net charge of 0 millivolts. Well, if this injury or this transmural infarct has an injury potential that's always releasing ions and causing the flow of electricity, and the vector of that electricity is away from the lead, then we will always have kind of a net negative flow of electricity away from the lead that's looking at that part of the heart. So if it's not 0 millivolts and we actually have a negative potential that's coming from that injury, what you start to see happen is the baseline lowers down. So because of that injury potential, you see the baseline moving down. So this is the direct result, or this lower baseline. So this lower baseline is the result of that injury potential. So because we see a negative vector, we're watching the electricity move away from the lead that we're looking at, that's going to pull this baseline down because the net flow of electricity is no longer 0 millivolts. Not a lot changes when we're looking at something like the P wave. So we know the P wave is going to be representative of our atrial depolarizing, so nothing changes there. We have atrial depolarization, which is represented by the P wave on the ECG, so our P wave looks the same. What's interesting here is our PR interval will continue to be at this low baseline because as we are at that point in between atrial depolarization and atrial repolarization, so not a ton is happening or we don't see a lot of movement, we can then see this movement again. So once ions have already finished moving up here to have depolarization, and we're looking at that point in between atrial depolarization and atrial repolarization and ventricular depolarization, we can easily see this injury potential moving away from the lead again. So our PR interval gets pulled down to this low baseline as well. The ventricle will then have its depolarization, so we get our normal kind of ventricular depolarization and atrial repolarization. So we'll see that happening as it was described before. So we're still having our ventricle depolarizing. So the ventricle is going to depolarize, and this is where we start to see changes to the ST segment. So the QRS complex will look as it does. The problem is that now we've had depolarization of the ventricle, or we've seen a huge net movement of ions within the ventricle during depolarization. And what happens is that counteracts the net negative movement from the injury potential. So we actually go back up to what we would consider the normal baseline. So you get this normal baseline, or ST segment goes way up here, because what's happening is ventricular depolarization, or the movement of ions during ventricular depolarization, is going to counteract the movement of ions that we're seeing with that injury potential. So essentially what's happening is our ventricular depolarization opposes our injury potential. What happens is because of that, because we have the opposing forces, so our ventricular depolarization opposes our injury potential, we go back to a millivolt of 0, or a net movement of 0 millivolts. So as a result, we actually go right up to what we would typically see in our baseline, and that's where you get that big ST elevation. So because we're going back to 0 opposed to the rest of the baseline that appears as lower because of the injury potential, so we start to see ST elevation on our 12 lead. So it's because all of the other baselines, when we look at any of the other pieces of baseline that we talked about, this baseline here, the PR interval, and the baseline following the T wave, all of those baselines can clearly see this vector moving away from the lead due to the injury potential. The only baseline that can't see that movement, or we can't see that movement happening, is the ST segment, because ventricular depolarization opposes the injury potential. So they counteract each other, which leads to a net movement of 0 millivolts. So we go back up to what we typically see in a baseline that has a net movement of 0 millivolts. And that's why you get this ST segment elevation in someone who's having a transmural myocardial infarction. So let's go through this in a stepwise way. So if we look at our ECG, one of the first things we need to recognize, or we know, is that when we have a transmural infarct, we start to see the flow of electricity away from that infarct, and we get a vector that moves away from our lead. So again, our lead is kind of looking here, the camera's positioned here to look at the flow of electricity, and an injury potential flows away, or a transmural injury potential flows away from our lead. So when we're looking at the heart at rest, or when it should be at rest, which is usually indicative of this piece of the ECG pattern, what we see is a lower baseline, or our baseline drops down because of the injury potential. So our injury potential lowers the baseline. What we're going to see next is what we typically see is we'll have atrial depolarization. So the atria is going to depolarize, and we'll get our P wave. So we can see the P wave will fire as it normally does. So we get our P wave here, which is our atria depolarizing, which I think we can all appreciate. And then the next piece is that we're in that in between. So the atria is depolarized and it's waiting for repolarization. So the atria is depolarized, waiting for repolarization. So we've seen that flow of ions, and now we're back to looking at a heart, or a pseudo resting heart, that we've had atrial depolarization. Now we're waiting for more electrical activity to happen. And if that's the case, we go back to witnessing this injury potential and the net flow of ions away from the camera, or we've got this vector that's flowing away from the camera due to the injury potential. So the same thing happens here that we discussed before, is that the injury potential is going to lead to a lower baseline. So it's the injury potential that's causing the lower baseline. In this portion of our ECG, we have our P wave firing that's causing this, or the atria is depolarizing, which is causing that part of the ECG. And then after the atria fires and we're waiting for repolarization or ventricular depolarization, we're back to witnessing that injury potential. So again, this low baseline, or this lower than normal baseline, is the result of the injury potential. Now, the next portion of our ECG, which is our QRS complex, we know what's happening here is we're seeing our atria has repolarized. We're seeing repolarization of our atria, and we're getting depolarization of the ventricle. So we start to see depolarization of our ventricle, and we get our QRS complex. So again, we're here, we got our P wave, QRS complex, and we know that that's the result of atrial repolarization and ventricular depolarization. And this is where things get interesting, is because now we should have our ST segment, and we know that that usually goes back to our typical baseline of 0 millivolts, or where we're at. What's happening here is the ventricle is depolarized. So we have a depolarized ventricle. We know we have this net flow or net negative flow of impulses coming from the injury potential, but the reason why we don't see the lower baseline here compared to here is because this ventricular depolarization has counteracted the flow, or the vector that is occurring because of the injury potential. So we know the injury potential is typically creating a vector that's moving away from our lead or moving this way. But when we have ventricular depolarization, that counters it out. So as a result, we see the baseline go back up to 0 millivolts, because ventricular depolarization, or having the entirety of the ventricle depolarized, counteracts the injury potential that we are seeing in someone who's having a transmural infarction. So we get a QRS complex, and we actually see our ST segment go way up here, or we get this big increase in the ST segment because we're seeing the ventricular depolarization opposing the injury potential. So we get that counteracting force, which allows this portion of our ECG to go back to 0 millivolts. So right here, we're seeing that kind of in between piece, and we can see that 0 millivolts because we get the counteraction of forces. So the ST segment rises because ventricular depolarization opposes injury potential. So this is the only time this person who has a transmural infarct, it's the only time that their isoelectric baseline can go back to 0 millivolts. All other times, we're watching that kind of negativity of the baseline because we're watching that injury potential flow away from the camera. So following this, we have ventricular repolarization. So the ventricle is repolarizing. We know that's going to lead to our T wave. So we have the T wave occurring here. So that's going to be our T wave as a result of ventricular repolarization. So we talked about that a bunch. And now we go back to a heart that is allegedly at rest. Now we know that because of the transmural infarct, we're back to seeing, because now the ventricular depolarization is no longer counteracting or opposing the injury potential, we can go back to seeing that injury potential that's going to flow away from our lead. So it's positioned, or the injury potential has that kind of net negative that's flowing away from our lead. So as a result, our baseline is going to go back down to where we saw it before. So the baseline goes back down to represent what we're seeing, or the injury potential. So again, these three portions of the baseline are all indicative of injury potential. So we're no longer witnessing a ventricle at rest or no net movement of electricity at those pieces. What we are witnessing is that vector of electricity moving away from the lead because of the injury potential. Up here, or the ST segment, we see that go up to the 0 millivolts during the ST segment, because when the ventricle is depolarized, that depolarization has counteracted the injury potential. So it's very challenging to see the injury potential in a depolarized ventricle, As a result, the ST segment goes up to zero millivolts, and that's where you get that elevation. This is a highly sensitive finding for transmural myocardial infarction when the patient doesn't have a mimicker. In order to complete our discussion about ST elevation in the transmural myocardial infarction patient, we should also discuss reciprocal depression, or why we would see reciprocal ST depression in someone who has a transmural infarct. And in order to do this, we have to take a look away from the lead that we're looking at. So, for example, if you're doing 12 lead on someone who has a interoceptal MI, we're looking at some of those precordial leads. Well, I want to look at the leads that look opposite to those leads. So when we're talking about ST depression, specifically reciprocal ST depression, we're no longer talking about the lead that we saw ST elevation in. We're looking at a lead that's looking at the opposite direction, or it's an opposing lead. So again, as we're looking at this lead is looking towards the infarct this way, we're looking at the opposing lead looking at the opposite direction of this infarct. So in order to talk about reciprocal ST depression, we're talking about the reciprocal lead or the opposite or opposing lead. So we're looking at the reciprocal lead, or the lead that's looking at a different direction or the opposing direction. And if we think about what this means, let's draw on our normal QRS here again. The big difference here is going to be at the direction through which we're watching the ions flow. So if you remember from what we talked about before, when we have an injury potential with a transmural infarction, it likes to move, or the net vector of electrical movement is away from the lead that we're seeing the ST elevation in. So we know that we have basically the net movement, or our vector of movement is away from this lead. That's what's causing the ST elevation that we see in our 12 lead ECG. Now, what's interesting about this is we just spent a whole bunch of time talking about how this net movement away from our lead leads to a lowering baseline and will eventually lead to ST elevation. So if we look at a reciprocal lead, we should expect the opposite. If we have a vector of electrical movement, or our electrical vector is pointing towards this lead or flowing towards our reciprocal lead, then it goes to assume that we should likely see an increase in our baseline. And that's exactly what we see. So when we have a transmural infarct and when our injury potential is creating the net vector of electrical movement away from the lead that is seeing the ST elevation, we see it moving away. In the reciprocal leads, we often see ST depression because we are watching electricity move towards this reciprocal lead, or the opposing lead. So just like we talked about before, what's going to happen is electricity moves away or toward a camera. It changes our baseline. At rest, or when the heart is supposed to be at rest, the reciprocal lead will be viewing this vector moving towards it. Remember when we talked about ST elevation, we said the vector is moving away from it. So because the vector moves towards the reciprocal lead, in the reciprocal lead, what you actually see is an increase in the baseline. So again, remember we talked about isoelectric baseline, our millivolts or net movement should be equal to 0. Well, that's not the case in the person who has the transmural infarct. We know that because the injury potential can be witnessed when the heart is supposed to be at rest. And in this case, because that injury potential is pushing electrical current, or we see the net flow of current towards that reciprocal lead, our baseline goes up. So anywhere where our heart is supposed to be at rest, our baseline goes up, and we see a change here. So we're seeing the baseline is moved up. Now, what's interesting about this case is, just like we talked about before, when the ventricle depolarizes, that counteracts any injury potential. So the depolarization of the ventricle, or when the ventricle is in the depolarized state, this opposes the flow of electrons that we see, or the flow of electricity that we see from that injury potential. So that is the only time that this injured heart, or this transmurally infarcted heart, is going to see that net millivoltage of 0. So again, when we look at the net millivolt here, it is actually 0. That's going to allow us to kind of go back up when we have our T wave. And then when we get back to this resting period, again, the baseline is increased because we can now witness that injury potential again. So again, the big difference when we're looking at reciprocal ST depression is what we're seeing at rest. And at rest, instead of watching the flow of electricity towards the camera or away from the camera, we're seeing it towards the camera in someone who has ST depression. So if we look at that, we can take a look again and do our kind of step-by-step view of that. Is we know at this portion of the ECG, this is supposed to be an isoelectric baseline. Now we're looking at the opposing lead. So let's draw our lead up here. So this is our reciprocal lead of someone having a transmural infarction. We'll draw on our infarcted area or infarcted tissue as well. So we know we have infarcted tissue here, and we know that that infarcted tissue has an injury potential that flows away or is flowing away from the infarcted tissue. Now, again, what's important to remember here is that the vector of this ion flow or the electricity flow is towards this camera, which is our reciprocal lead. And as a result, our baseline, what happens to our baseline is it starts to go up. You see an increase in our baseline because we're watching that electrical current flow towards our reciprocal lead. If we go to our next stage, then we're going to see atrial depolarization. And as we've talked about before, that's going to cause our P wave. So our baseline is way up here. We are going to see our P wave, just like we always do when we have the atria depolarize. And then when we move to our next step again, we know that the heart should be at rest, or we don't have any net flow of ions. So in this case, the ventricle or the atria has already depolarized, so we've had atrial depolarization. It's in that kind of in-between period, so it's just waiting to repolarize, so there's no net movement of ions. And as a result, we're back into a position, because the ventricle hasn't done anything yet, where we can see that net flow of electrical activity. So, and we know that's going to move towards our reciprocal lead. So we've got, then again, the net flow of electricity towards the reciprocal lead. So as we look at the reciprocal lead, that PR segment goes right back up to that baseline that is indicative of the injury potential. What's going to come next is our ventricular contraction. So we'll see our QRS complexes like we expect to see. So we see depolarization of the ventricle, which is going to result in our QRS complex. The atria is going to repolarize at this point. So we won't shade our atria in because it's repolarized, or it's in the process of repolarizing. And we have our injury here, but we can't really see it because we're watching that big ventricle depolarize. So when you have this big massive tissues repolarizing, it's really tough to see anything else that is going on there. So as a result, we get a typical QRS complex. And this is where things get a little bit different, is that we now can no longer see the injury potential. So after the ventricle has depolarized, and this is what we chatted about before, is because the ventricle is depolarized and we've had the net movement of ions during ventricular depolarization in this large massive tissue, so we're talking about the ventricle depolarizing here, this hides or opposes our injury potential. So just like we talked about in ST elevation, what's going to happen here is we're not going to be able to see the injury potential. The ventricular depolarization, or the ion movement that we've seen during ventricular depolarization, negates or opposes that injury potential. So instead of going back to that high baseline that we see with the injury potential, we get this ST depression. So what we're seeing here, or that's the specific reason that we see ST depression in that reciprocal lead, is because although our baseline is high in these areas, we can go back to a net millivolt of 0 here, because ventricular depolarization is essentially opposing all the other electrical forces, or opposing the force of the injury potential. Now, as we have our T wave, so we're going to see repolarization of the ventricle, then we're going to move back up. So as the ventricle repolarizes, or basically won't draw anything here to show the ventricle is repolarized, we have our T wave, and then we're going to go back to our baseline, which, remember, when someone has a transmural infarction, the baseline is created or is being generated by that injury potential. So now we're back to having no real movement of ions from the myocardial tissues, other than the movement that we're seeing from that injury potential. So the injury potential gets to be the boss again, or the injury potential is what's going to be witnessed by the opposing. And remember, this is the reciprocal lead. So as a result, our baseline is going to move right back up to where we saw it with before the P wave, during the PR interval, and after the T wave. So we get reciprocal depression. So again, it's one of the reasons why when someone doesn't have a mimicker and you have ST elevation on the 12 lead, they have clinical symptoms of heart attack, and you see reciprocal depression, again with no mimickers, very sensitive for ST elevation MI. So I hope this helps clear up why we get ST elevation in myocardial infarction, as well as why we see reciprocal depression. It all has to do with the camera angle or the lens angle that we're looking at with our lead. Are we looking at the injury site and watching electricity flow away, or are we looking at the opposite side to the injury site and watching electricity flow towards our lead?